Hospitals. I'm Dr. Ann Borik, board certified at internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio. Joe, how are you today?
I'm great. You, Dr. Borik?
Good, good. DocTalk Radio is sponsored by Gilbert Hospital and Florence Hospital at Anthem. Well, I got to tell you, we have a fantastic show in store today. I am very excited to introduce Dr. Saggar, who is the Director of Pulmonary Hypertension, Pulmonary Fibrosis Programs, and the Assistant Director of Pulmonary Lung Transplantation at St. Joe's.
That's correct.
Dr. Saggar, thank you for being here.
I appreciate the opportunity to come.
You know, that's a lot. I'd love for you to just tell us a little bit about really what you do in your background.
Well, first of all, it's an honor to be here. And, I actually come from California, just moved here exactly 1 year ago. So completely enjoying the hot summer weather.
I bet you are.
It's nothing to brag home about. But it's actually been a great move. Prior to coming here, I actually was at UCLA. I did my Pulmonary Hypertension and Lung Transplant fellowship over there. And then I stayed on faculty there for about 4 years, where most of our time was spent mostly in taking care of patients with advanced lung disease, mostly rare lung diseases such as pulmonary hypertension and pulmonary fibrosis. And eventually when those conditions go beyond medical therapy, that leads to lung transplantation.
Wow.
And so the majority of the time was spent initially learning, the ropes and how to manage these patients, and eventually actually taking care of them. And I knew some of the individuals who started the program here out at St. Joseph Medical Center in Phoenix.
Right.
They started a lung transplant program approximately about 5 years ago. They just did their 100th patient.
Wow.
And it's headed up right now by Dr. Rajat Walia, and from the surgical side by Dr. Michael Smith. And some of these individuals were down in California before they came to Phoenix, and I met them and decided this was a great transition move for me. And it's been wonderful over the last 1 year, meeting all the people and taking care of the people in Arizona and some of the surrounding states.
It's interesting. I've been practicing here for probably 18 years or so, and a lot of the physicians really are not aware that there's a lung transplant program here in Phoenix.
Yeah, that's right. I think usually when you think of organ transplantation, you usually think of a large university center.
Right, Tucson, we send them, or UCLA, or...
That's right.
Mm-hmm.
And unfortunately, the Tucson program has been put on hold. And fortunately for us, the success of the program has been built around mostly through sort of word of mouth, and then also through educational seminars with other pulmonologists and also internists and family practice individuals to let them know that there's actually a program out at the community center, and that there's patients where many physicians feel there may not be a candidate, but we encourage that at least we evaluate that individual on the chart and let us make that assessment, especially if there's no other medical option for them.
Exactly, and we'll talk a little bit about what the indications are for lung transplantation. But first, I want to talk about pulmonary hypertension. That's a big word, that encompasses a lot, and I'd love for you to kind of shed a little bit of light, especially for our listeners. What is pulmonary hypertension? How do you diagnose this? How do you treat it? People listening, if you want to call in and ask questions, I would encourage you to. This is a real opportunity. Rarely do we have the director of a lung transplant program, and pulmonary hypertension and fibrosis in the studio with us. The number is 480-745-1033. So, I'd love to hear from you in reference to our topic today. But pulmonary hypertension, what is it?
This is actually a topic that's very dear to me. I've spent, since I was into my residency, doing research in clinical studies and really spending the majority of my time into this rare condition. But it's exactly what it says. Pulmonary is, of course, the lungs, and hypertension is blood pressure. Mm-hmm. So in this case, it's high blood pressure, but within the lungs.
Right.
So I try to explain it to patients just as when you go into the doctor's office and they put a blood pressure cuff on your arm, that's giving you a certain type of blood pressure, let's say 120/60. Well, the lung also has a certain set amount of pressure inside of it, and it's actually routinely a very low pressure system. And when you develop pulmonary hypertension, usually what that causes is that blood pressure elevates within the lung circuit due to abnormal vasculature of the lung itself, and that feeds back into the right side of the heart. And over time, what happens is that these patients eventually get extremely short of breath. And ultimately, if their disease progresses, they eventually will pass away, usually due to right-sided heart failure. So a lot of the times it's a toss-up between whether this is really a field for pulmonologists or for cardiologists, because it's actually involving both the right side of the heart and the lungs. And it's a very unique field, because in general, when you think of cardiology and you think of what their field entails, most of the issues is dealing with high blood pressure, cholesterol, heart attacks. That's really focusing on the left side of the heart. And we have a lot of fabulous medical therapy available to modify the left heart and to improve patients' survival and symptoms. But the right side of the heart is kind of what we think of sort of the black sheep of the family. It's kind of the ignored side of the heart, because the right heart's job is actually, its sole job is to pump blood into the lungs. The left side of the heart's job is actually to pump blood into the entire circuitry of the body. We got to pump oxygenated blood to the brain, to the gut, to the limbs, so we can live, breathe, eat, do whatever we want.
Right.
So the left side of the heart is constantly working as a muscle. It's constantly getting stronger and adapting. When we're born, our right side of the heart only realizes it has one job. It's to send the blood into the lungs so we can oxygenate the blood. That blood then goes to the left side of the heart, and the cycle continues. So the right side of the heart really doesn't have to really function too much over decades and decades. And let's say that a patient comes in now, she or he is 45 years old, and now has become short of breath. And we realize somehow we've diagnosed them with pulmonary hypertension. What's happened is that in the last 1, 2, or maybe 3 years, that right side of the heart recognizes that the pressure inside the lungs has gone high. And as a muscle, it tries to adapt. But now it's 40 years old. And it's just like if you walk into the gym and you say, for the first time I'm going to pick up a 60-pound dumbbell, I'm going to curl it with my arms. What happens is your arms fatigue. And this is what happens to the right side of the heart. It says, you know what, I can't do this job, so I'm going to try to dilate and get bigger. But unlike the left side of the heart, when it starts to do it, it's maladaptive because it's 40 years old and hasn't had time to develop correctly. And it actually starts to, unfortunately, fail. And the patient basically develops its signs and symptoms. What those are actually signs mostly of shortness of breath, a decline in the patient's exercise tolerance. That means that normally they're able to walk a few blocks, and they say, you know what, every time I go to the grocery store, if I pick up something and I walk a little bit, I get really winded. You can also develop signs of chest pain, where it's not actually it's not heart attack findings, but it's actually chest pain because the heart's strained on the right side. Other things that can happen if the right heart starts to fail, you develop what we call fluid overload states, where you develop fluid in your belly or fluid in your lower extremities. We call that edema. And in severe cases, the patient, when they start to do some sort of exertional activity, like stand up, they can actually faint, and we call that syncope. So these are signs and symptoms that are very hard to know as the pulmonary hypertension, because a lot of normal conditions can cause shortness of breath, chest pain, swelling of the limbs. So it's very important that the physician recognizes that the first thing we need to do is we need to do an exhaustive diagnostic workup to find out why is the patient short of breath, because most likely they may have common conditions such as high blood pressure, or they may have sleep apnea, or they may be a smoker and they have lung disease of sorts. So it's important that we do a good history and physical, find out what potentially what is the patient's symptoms, what's their complaints, and then we move into, of course, what's called non-invasive testing. So for that, what that means is we can maybe do breathing studies, which are called pulmonary function tests, to find out, do they have any intrinsic airway disease like emphysema or pulmonary fibrosis. And then we do what's called an echocardiogram. And the echocardiogram is our first kind of insight into what that right side of that heart looks like. And so it's really what I believe is the key test. And it's very important that whoever is going to be your echocardiographer, and then therefore your cardiologist who's going to read that test, that they understand what you're actually looking for. And in this case, we're going to say, well, we're looking for actually both sides of the heart. What does the left side look like? Because that's what normally the cardiologist will focus on. But for our condition, what does the right side of the heart look like? And, maybe about 5 years ago, the right heart was actually quite ignored, and we never even talked about it on the echocardiogram, even though the images were there. So a lot of education has happened, and we're now able to actually see, is that heart, does it look normal? Does it look dilated? And when it beats, does it beat in a very normal rhythm, or is it what we call hypokinetic? It means that it's kind of, it's not beating as vibrant as it should. It kind of is weakened.
Right.
And that's a very nice insight into what's happening without putting the patient through any sort of invasive test. Once we've done these sort of tests, we do a bunch of laboratory studies, because, as we said, one of the main symptoms is shortness of breath. Well, common things such as low blood counts or low hemoglobin, which is termed as anemia, can be there. So we want to check for anemia. We want to check thyroid dysfunctions, because patients who have low thyroid, or what we call hypothyroid, can actually develop shortness of breath, or they can have lethargy, or they can have a decline in exercise ability.
And that's an easy fix. Right.
And those are all easy things that the general practitioner can absolutely take care of. So these are the things that need to be ruled out before we move forward with anything. Another thing that can always cause pulmonary hypertension that everyone should look out for is a blood clot in the lung, and that's termed as pulmonary embolism. And so there's really two tests that can be evaluated. In the pulmonary hypertension world, we believe that what's called a ventilation perfusion scan is a very simple test. It's a nuclear medicine test where you're given a radioisotope. So it basically dissolves over time, and you basically lie down, and it sort of takes pictures of your ventilation and also your blood flow through your lungs. And if there's a mismatch, then we think there may be a blood clot. Another test that we can do to that often is done is what's called a CAT scan, but it's called a CT angiogram of the chest, where we're specifically asking the radiologist to give iodine, and that iodine goes into the vessels of the lungs, and we're looking to see if there's actually a blockage within the lungs. The same thing that the cardiologist does when they do an angiogram. You're basically looking for a blockage, and if you find it, that's called a pulmonary emboli. And again, that is something that we need to treat with blood thinners of sorts.
Now, is there a risk of developing pulmonary hypertension in people who have chronic PEs and that kind of thing?
Absolutely, and I think that's where we're sort of going with this discussion, that probably so what happens is a lot of patients hear about people flying and they develop what's called an acute pulmonary emboli, or they're pregnant and they have a blood clot. There's individuals who, unfortunately, despite us giving blood thinners such as Coumadin or injectable like Lovenox, what happens is that that blood clot actually persists, and it actually multiplies. So it's usually they can develop a syndrome called chronic thromboembolic disease, and it's exactly what the name states, chronic. That means that this process is not acute, but it's been sitting there now for a while. Thromboembolic means it's actually bilateral in both sides of the lung vessels. So versus an acute pulmonary emboli typically is usually like in one side of the lung or in one segment. The chronic actually is multiple areas. And giving blood thinners is appropriate, but it doesn't fix the problem. And if they develop, if that process stays still, remember that right side of the heart, once again, is pumping blood into that vessel. And if it recognizes that, wait, there's a blockage, in other words, it has a pressure gradient is starting to rise inside the lung, and they're developing high blood pressure to the lung. And as a muscle, it has to adapt to that high pressure. So what does a muscle do when it says there's a high pressure system? It tries to dilate and get bigger. Okay? And like we said before, that right heart now is not prepped, or it's not adaptive, and it's too acute of a process. So the right heart quickly dilates, but in doing so, it actually becomes maladaptive.
It weakens,
And it weakens, and the patient's symptoms of shortness of breath progresses.
So I know we have some questions coming up, but I want to kind of just finish this conversation about pulmonary hypertension. So the causes of pulmonary hypertension, I know that there's some link to some diet pills and those kinds of things. I would love to hear, your insight about that.
Yeah, so I mean, unfortunately, fenfluramine actually made this field very recognizable for the scientific community, because back in the days when fenfluramine, which was a dietary supplement, was allowed,
it was fen-phen.
And fen-phen was his sort of trade name, which it went by. In those patients, they would develop two sort of fatal abnormalities. One was sort of a valvular abnormality of the heart, and the second thing is they would actually develop pretty severe cases of pulmonary arterial hypertension.
Wow.
And this brought on a whole, of course, illegal suit. But what it told us was that there was a lot of individuals who took fenfluramine, and especially in the female population, there seemed to be a small group of those individuals who would suddenly, and the first case was actually within the first month of exposure to fenfluramine, they developed severe shortness of breath, and many of these patients were dying essentially of right heart failure. So a lot of research was poured into that. What is this pulmonary hypertension, and how do we fix it?
Right.
And this further went on to see, okay, well, what are the etiologies that develop pulmonary arterial hypertension? The most common cause, unfortunately, is actually called idiopathic pulmonary arterial hypertension. It used to be called primary pulmonary, and these were these unfortunate cases of very young females, about the age of 30 to 40 years old, who were otherwise healthy, and within about a year or two would become severely short of breath,
Wow.
and then develop severe right heart failure and succumb to death.
And really not know what it was due to.
Have no idea what it's due to, and that still makes up about 50% of all the cases in the United States. What's now become more well known is what we call associated conditions, and the most common links to that is something once again very dear to me, is what's called connective tissue disease or autoimmune disease, and this is a case where the patient's own sort of body starts to fight itself. And in certain types of connective tissue disease, like what's known as scleroderma, which is a disease where, a condition where individuals can develop thickening of their skin and also develop organ abnormalities, one of them being pulmonary hypertension, another one being pulmonary fibrosis. There's also a link to lupus. And those are probably the two most common types of connective tissue disease that can develop pulmonary hypertension. And in fact, what we now know, specifically in scleroderma and scleroderma with lupus sort of overlap syndromes, that pulmonary hypertension is the highest risk for having significant problems, or in other words, death.
Interesting.
So we pay very close attention, and we work all these patients up for pulmonary hypertension if they are short of breath. In California, at least, and I'm sure also nationwide now, there's a huge increase in the use also of smoking amphetamines. And we see, unfortunately, a lot of those individuals now coming in with both left and right-sided heart failure, but a lot of them are actually dying of pulmonary hypertension. So just like the fen days, where there was sort of like this amphetamine link, also individuals who are using drugs like amphetamine and even cocaine, there seems to be a high risk associated with the development of pulmonary hypertension.
Is there an association with marijuana smoking or anything like that?
So at this point, there's no association with either tobacco or marijuana use.
Okay, good.
Yeah.
I know we have some questions, and this is a great conversation. Joe, what do we have?
Let's just start with our first question here. What is fibrosis?
So pulmonary fibrosis, so when you look at a lung, the lung is made up of really two major components. One is the airway, and the second is the vessels. So every organ has its own blood supply and its own sort of parenchyma. And in the lung case, we have what's called alveoli. And the surface area of a lung is actually quite large. If you open up both lungs, they say it's about the surface area of a tennis court. Wow. So there's a lot. It covers a lot of area. And the lungs, as we said, its job is to really do one thing, and that's to exchange gases. We want to bring in oxygen, and we want to blow out carbon dioxide. And we want the lungs to fill up with blood so it can do its job.
So it's dynamic.
It's very dynamic. You take a deep breath in, we blow it out.
Right.
When you develop pulmonary fibrosis, the term fibrosis essentially means scarring or inflammation of the lung. And it's characterized as what we know as a big terminology called interstitial lung disease. And in this population, what happens, for some reason, there could be various exposures, so toxins like chemicals, patients who are sandblasters, patients who actually cook the kettle corn in the kettle corn areas, various types of chemical exposures that may be toxic, pigeon exposure, so individuals who are exposed to chronic pigeons can develop what's called hypersensitivity pneumonia. But the most common cause, once again, leads us back to this term idiopathic.
Right.
And idiopathic, once again, means that no matter what we try to look for, we can't find an association or an exposure. And therefore, we come up with this term, the patient develops idiopathic pulmonary fibrosis, or the term is called IPF.
Right.
Typically, IPF is a condition most common in men with probably a 2-to-1 male predominance.
Interesting.
Usually happens in the ages 50 to 60, where, again, once again, the person was very healthy and starts to develop what, of course, with the lungs is shortness of breath. They can develop a dry cough. And essentially what starts to happen is the lung initially gets inflamed. And when the lung gets inflamed, it tries to heal itself by bringing in sort of our inflammatory mediators.
Right.
But unfortunately, when it tries to heal itself, it actually starts to scar. It's very similar to like if you get a paper cut on your finger, and then you see that scab start to form.
Right.
Initially, it's red, that's the inflammation, and then you start to get sort of a crusty feel. So you can imagine the lung is supposed to be very dynamic. And if you start to form these scars all over the lung and you take a deep breath, it's kind of like a balloon that's stuck in your pocket, and you try to inflate it, and it inflates partially, but that stuff that's sitting there for a long time, you can't inflate it. So you actually restrict that lung from blowing up. It's almost as if you applied like a cement coating to part of the lung.
Wow.
So you have trouble taking a deep breath of air, but you can blow it out very well. And so what happens over time is, unfortunately, the scar formation tends to continue.
Right.
It can be extremely rapid, and the average survival once you develop idiopathic pulmonary fibrosis is on the order of about 2 to 3 years.
Oh, wow. And that would be somebody that would maybe meet criteria for a lung transplant.
Absolutely. There's a whole host for types of conditions for lung transplantation, but one of the two most common conditions for lung transplantation, in fact, are pulmonary fibrosis. The largest one is, of course, emphysema or COPD, usually smoking associated. And one of the rare causes, in fact, is still pulmonary hypertension, because once they do fail what we call medical therapy, we have to do something for the patient. And the next step would be to transplant their lungs.
Great. We'll talk more about the lung transplantation, but are there any other questions, Joe?
Yes, we've got Boris, 68-year-old male, level 4 cancer patient. Do herbal vaporizers work as an acceptable measure to medicate, or do they damage the lungs as well as smoking?
Well, I think that's a very difficult question, and obviously a person who's going through a lot. So the question is that does herbal vaporizers sort of improve probably the sense of dyspnea or shortness of breath, and and do they have any side effects to the lung? I guess I would probably respond that in this particular case, if he feels like the herbal vaporizers are making him feel better, and he feels like he can breathe more easily, then we probably would not say not to do it. Whether or not they cause injury to the lung, we would have to know sort of what is being vaporized. If it's sort of just humidified air, absolutely, that's perfectly fine. If it's any sort of unique sort of smoke or chemicals or stuff that we may not be familiar with, then we would probably say that you may want to try to avoid that, especially if it triggers like a cough or it causes any sort of wheezing symptoms, and then maybe you're having a bad reaction to that.
Yeah, I would be careful. Yeah.
How safe are medications that are used with nebulizers and ingested via the lungs?
Well, so the concept of a nebulizer is actually quite unique. The reason they were actually built was that we feel that there's some medications that when you actually nebulize or inhale it directly into the lung itself, rather than giving you a pill, let that pill digest into the bloodstream and somehow filter into the lung, the concept of directly administering it into the airways of the lung can be advantageous. So most of the medications we nebulize, such as like albuterol or even certain antibiotics, can be very effective through that route. And actually, even in pulmonary hypertension, we have one of our medications is actually, it used to be delivered through injectable meds, but now we have an inhaled version where it's the same exact concept that if you inhale it, it actually goes right into the area of interest and hopefully acts on that, minimizes the systemic side effects of the drug. So I would think that nebulized medications are extremely successful in doing what job they need to do.
And we use them all the time.
Absolutely.
So yeah, I think that's good.
Sarah, 52-year-old female from Nashville, Tennessee. Been a smoker for 20 years. I quit 2 years ago. Every once in a while I have one when I have a drink. Will my lungs heal and be like new eventually?
That's a great question. So first of all, to Sarah, that's congratulations on quitting smoking. I think that's the hardest step to do and to maintain that. And the answer is absolutely yes. So in all our smokers, unfortunately, when you smoke, you continue to have deterioration of your lung. When you stop smoking, the lungs do tend to recover. They may not go back to perfectly normal, but that injury process does stop. And it usually takes about 5 to 10 years to try to get back onto the same sort of normal deterioration that everyone who doesn't smoke or doesn't have any lung health effects, we all have a sort of eventual health natural deterioration. So those two curves of Sarah and someone else will start to meet at about 5 to 10 years.
And it is true that secondhand smoke can be detrimental to the lung as well.
Yeah, absolutely. I mean, I think it's one of the more difficult things to sort of assess that, you know, how much exposure actually led to potentially their lung injury. I think what probably is that that particular individual already was predisposed to develop some sort of lung condition, and that secondhand smoke may have sort of, you know, tipped him over or her over at that point in time. So I think even secondhand smoke ideally should be avoided if possible.
Very good. Anything else? Good. You know, let's talk about lung transplantation. It's a fascinating topic, and there's a lot of questions that even, you know, myself as a primary care physician, internal medicine, have. You know, who meets criteria? Talk a little bit about that.
Yeah, I mean, it's so, you know, it's pretty remarkable what organs we can transplant, and you know, once I became involved with this field, I've been fascinated to know that there's really almost any organ that you can transplant.
Wow.
I mean, you can do lungs, heart, pancreas, skin, hands,
Corneas.
I mean, it's really remarkable the technology that's out there in the science. Unfortunately, lungs are one of the most difficult organs to transplant. It's unique because one thing differentiates the lung from everything else is that the lungs are constantly exposed to the environment. Every day we breathe the air, the ambient air. The difference is if I transplant a heart, the heart actually is encased into its own sac. It's protected from the environment. It's the only thing that it's exposed to is your bloodstream. Well, the lung is also exposed to that same bloodstream, but we can't control the viruses that we breathe every day, the fumes, the exhaust, you know, all that other stuff. So there's a lot of different things that can affect the outcome of the lung. In addition, we have our gut. And every day as we swallow, we develop a lot of acid. And if we develop a lot of reflux and it goes into our mouth and then part of it dips into the lung, that can also injure the transplant lungs. So when we think of lung transplantation, it's really reserved for individuals who we believe have a lung condition like COPD, like pulmonary fibrosis or pulmonary hypertension, that we believe that their overall survival in the next 1 to 2 years is extremely impaired. So either they have a high risk of passing away, or their quality of life is so impaired. In other words, you know, they can barely walk from their bed to their bathroom without almost feeling like they're going to pass out.
Right.
In those cases, you have to fail medical therapy, whatever is being offered. You have to be oxygen dependent, and at that point, we will say, okay, we want to evaluate you for lung transplantation because there's really nothing else we can offer. And at that point in time, we bring the patient into clinic.
Let me ask you a question. Is there an age cutoff? You know, as I'm thinking about patients who, you know, to refer to you.
Well, yeah. So, you know, when they come into clinic, the first thing we evaluate is their age. And typically, you know, back about, 5 and 10 years ago, that typical age cutoff was 60 to 65 years old. Because we felt that after 65 years old, that normal age-related problems like, heart disease, bones sort of fracturing, hip replacements, those are starting to increase in the amount of time. So, and what we've decided at St. Joseph Hospital is that, age is a relative issue, but we definitely transplant people who are 70, 71, 72. We do have an absolute cutoff of 75. So the gray zone is about 70 to 75, and we take it on an individual basis.
Very good.
But this does allow a lot of patients who can be turned down at other centers, even in other states, that may be 66 years old, and the center says we can't transplant you, that we will take a look at it. And we have many patients, especially like from Colorado, from New Mexico, even from Southern California, Northern California, that say, we were evaluated at so-and-so center. They said we were too old. We see them and we're like, you know what, the only problem is your lungs, and otherwise you seem very healthy.
Viable and healthy, right.
And we've done a workup, and the rest of your exam shows that you are, and we're willing to take this chance. But, transplant is not for everybody. It's a huge investment from the patient side of their time, their family's time. There could be money involved because the medications can be expensive. And this is a lifelong process. Right. We're basically taking out your organs and we're implanting someone else's organs in. And the first thing the body says is that these don't belong to me. And just like if I swallow a virus, or if I inhale, if I inhale like a virus, and I get an infection, my body reacts. We get a fever, we get coughing, we try to get rid of the sputum.
Right.
Well, your body tries to attack the lung. So the first thing we do is that we have to give them multiple amounts of medications. They're called immunosuppressives. These drugs are like prednisone and special types
to quiet the immune system.
Absolutely.
Right?
The first thing we want to do is to bring that immune system down and allow the lungs to live and not be attacked by our own body. The problem is when you do that, whenever you reduce your immune system, the first thing you're predisposed to is infections, bacteria, viruses, funguses. So it's a balance between how much do we bring down your immune system, and then what is the risk for infection. Once we transplant an individual, getting him through the first immediate postoperative period is the first big hurdle. That typically is about a 11 to 14 day period while they're in the hospital, where they wake up, they realize they have a new lung. It's almost like it's an amazing experience to be part of when the patient realizes they always say the same thing. They say, I can feel I can breathe. And that's,
it's like a miraculous experience, I'm sure.
It's an amazing concept that just a few hours ago they couldn't breathe.
Right.
And many of them were on the doorstep for not doing well, to where now they're having a very successful time. But we always have to caution patients and say, listen, this is exactly like a wave that you're riding. Sometimes the wave is going in the right direction. Other times it's very aggressive and powerful, and you topple over and you have side effects and you get sick. So transplantation is not meant for everybody. It's meant for the right patient. And what we tell the patient is that you have to look at what's the overall survival rates after lung transplantation. So in a very simplistic way, 10% of our population passes away after lung transplantation every year. So at 1 year, 90% are alive. And at 5 years, at St. Joseph, our survival is a little bit better. It's about 55%. And so what that means, after 5 years, half the patients are alive and half, unfortunately, are not alive. And so that kind of gives the patient an estimate of what sort of risk they're going to be taking.
Right.
Now, if you have a lung condition where before transplantation we give you a survival rate of about 6 months to a year, well, then I think this risk may be acceptable, because without the transplantation, you don't have any hope.
Right.
So it's worth taking that chance. But I think what's important to stress is that we really need a lot of family support. And I think that's the really untold story. The spouse, the significant other, the children, these are actually what we call the silent patients. These are the individuals who are really going to make sure that the person who got the transplant is compliant with their medications, come to their weekly visits for the first 3 months. They're being driven everywhere. They're being watched. They're being coddled to make sure that they undergo their physical therapy when they have pain. And, you have to go through the emotional swings of what comes with transplant, because unfortunately, remember, like I said, if we did 100 transplants, 10 patients would not do well. So it's those patients that rely on, the transplant team and the family.
Now, in smokers, how long do they have to be a non-smoker in order to meet criteria to be a transplant patient?
That's a great question. I think, I've sort of glossed over that. The two main sort of contraindications for transplant is, one, you can't have cancer.
Okay.
And that can be any sort of cancer. And the second thing is that you can't be an active smoker. We recognize that smoking causes the underlying lung disease, but the first thing we need to make sure the patient does is be compliant and stop smoking. The average time duration is roughly about 6 months. And it's not easy to trick the system, because we can check urine tests. It's called a urine cotinine study. And so we know if you had a cigarette in the last 30 days. So we can pick up, and so we always tell patients that even one cigarette will be able to know. And it's not that we're judgmental from a social standpoint. It's because smoking has caused the initial condition, and we are very concerned what smoking is going to do to that transplanted lung.
Right.
So we try to minimize all the sort of toxic processes that
which
we can
makes
avoid.
sense.
Yeah,
that's good.
Tensu from Augusta, Maine says, rather than going on a list, is there a resource to purchase lungs, or is there an artificial lung like a pacemaker for the heart?
Well, so the first question is that, is there a way to purchase lungs? So at this point, there's actually, in all organ transplantations, there's no way you can actually purchase an organ at this point in time. In the United States, there's a selection process. You have to be placed on the list, and just like everyone else, and depending on how sick you are, the sickest usually get the lungs first, and then you sort of move up the list as that sort of happens.
Right.
So you can't purchase lungs, nor do we advocate that. From the second question, is there an artificial lung? I mean, I always say that the pulmonary field is about 30 years behind the cardiology field, and I don't think it's because cardiologists are smarter. I think because the lungs are actually a very complicated system.
Right.
So we don't have any sort of artificial lungs available where you can, implant just, a partial thing and it keeps the lung alive, unfortunately. That technology, I don't even see in the foreseeable future at this point in time.
I mean, it's more than just a pump. It's the dynamic of exchange of gases.
Exactly.
And I'm not sure that that's reproducible.
That's a very good point. I mean, you have to do two systems in one.
Right.
You have to, exchange the gases and do it. I mean, it's essentially being on like a ventilator at this point in time. And,
Right.
and of course, you can't function just on a ventilator. You can't move around like that. What is actually pretty exciting is that there is an ability now to when the organ is given by the donor, whoever passed away, a lot of these organs are very difficult to implant, because let's say someone has a trauma and their lung gets a hematoma or a contusion, or they get a bad pneumonia.
Right.
Well, then we can't use that lung. There's now technology that's coming to the United States where we can actually take that organ and literally put it in its own kind of virtual environment, re-nurture that organ back to life, and eventually, just like in Canada, what they have in the United States, will have this in about 10 years, where you will come in, we'll say you're going to get a lung transplant, you get on our list, and we will say come in on August 26th at 8 a.m. because we're going to do your transplant.
Wow.
Because now that lung is being nurtured for you. So it's a very exciting field. They're starting it already with hearts, and we'll get to lungs, and you can imagine the amount of patients where we have such an organ shortage right now. We can help so many more patients out in the near future. So we hope to carry this technology at St. Joseph. Also, we already have one of our surgeons is being trained in this sort of technology named Dr. Ashimi. So we're very excited to hopefully bring this over in the next 1 to 2 years and start at least the research concepts of it.
Wow, that's fantastic. Dr. Saggar, why don't you just give us a little information on how people can contact you? I mean, do you have an office, a location, or you're at St. Joseph's Medical Center in Phoenix?
So we're at St. Joseph Hospital and Medical Center. We're part of what's known as the Heart Lung Institute. We're actually located on the corner of kind of Central and Thomas, specifically 5th Avenue. We're part of the 500 West Thomas Road MOB building. And they're more than welcome to contact us. Our number is area code 602-406-4000, and that'll get you into the Heart Lung Institute. And at that point, they will ask you, what is your condition, and then we'll be more than happy to take it from there.
Now, St. Joe's has been recently, it's one of the top 10 centers, or tell us a little bit about that.
Yeah, well, so St. Joseph is well known, of course, for their neurological surgery,
right, Barrows
and the Barrows Institute. And what we're trying to do with the Heart Lung Institute is actually to mimic that same success, but within the lung issues. And from a lung transplant center, we're now open for 5 years. We're now over about 140 lung transplants in those past 5 years. And so in terms of years per year, the number of transplants, we do between 40 and 50 lungs a year. That puts us at about in terms of size, about number 10, 11, 12 in the United States.
Wow.
So in the last 5 years, we've built a large program, a very successful program. We have a 1-year survival of 89%, which puts us again in the top 10 percentile.
It's amazing because a lot of my colleagues, we don't realize that.
Yeah.
And it's just so good to know. That's great. Any other calls or questions, Joe?
Nope, but if anybody wants to call in right now, you can do so at 480-745-1033. All questions and comments welcomed.
Let's talk a little bit about exercise. Somebody that's on oxygen. What is your recommendation for exercise? Can they exercise, or is that something that they shouldn't do?
I think that this is probably when it comes to when patients say, what can I do to make myself healthier?
Mm-hmm.
I mean, this question comes up again and again. And, it's almost like a hip move where the physician says, oh, why don't you eat healthy and exercise?
Right.
But actually, when it comes to having lung conditions like emphysema or pulmonary fibrosis or even pulmonary hypertension, one thing you can do is that you can take a organ that has limitations, and the purpose of exercise is actually to improve the muscular function of the rest of the body. So you can get the muscles in your quadriceps, in your calves, in your arms, in your abdominal section.
Right.
All these muscles are to improve as they get stronger. They improve the efficiency of the system.
Mm-hmm.
It's like what I always tell my patients. I said, it's like you have the same car for 10 years and you take it for a tune-up.
Right.
It's the same engine, but why are you now getting more gas more mileage per gallon?
Mm-hmm.
You're just tuning it up. And so what exercise or physical therapy or what's known as pulmonary rehabilitation, it is extremely successful in doing exactly that. Basically what they do is that they put you on a regimen. You go 2 to 3 times a week for roughly about 6 to 8 weeks. So one, you have a trainer, almost like a personal trainer.
That's
in this
great.
case, it's a physical therapist who is knowledgeable in that disease state. They have oxygen supply, and they gear their protocol or their exercise regimen to your condition. And over those 6 to 8 weeks, the goal is that you're going to be able to walk farther, you're going to be able to do more exercise for a longer period of time, and you're going to do it all while your lung we haven't changed anything.
Mm-hmm. Right.
It's still as limited as it is, but the patient, without a doubt, in the majority of cases, will walk farther, will feel they're stronger, and they'll feel like they can do a lot of things. What they have to do after that point is that they have to transition that exercise regimen to their home, and they have to be able to continue to do that. I mean, that's what even normal patients without, if we don't have any health problems, I mean, getting myself to the gym and forcing myself to do that every single day or at least 3 times a week. I mean, listen, it's difficult.
It's difficult, right?
So you have to have that sort of drive to continue
that
it.
discipline. Mm-hmm.
And I think that physical therapy and pulmonary rehabilitation is crucial to the success of a person or a patient with lung disease.
Now, diaphragmatic breathing, some of the breathing exercises, is that part of what they teach? Because most people are shallow breathers.
That's right.
Let's face it.
That's right. And you can imagine that if you have a lung impairment, you breathe even more shallow, more rapid.
Absolutely.
And it's a vicious cycle because you get panicky. It's like if you go into the swimming pool and you feel like you're suffocating, it's a horrible sensation.
Mm-hmm.
So what the physical therapist does, despite all the exercise training, they will also instruct the patient how to breathe through those periods of almost like high respiratory rates or panic states or acute shortness of breath. And they train you to breathe, sort of take a deep breath in and sort of purse lip breathe out. Okay, so sort of learn how to slow down that respiration. And it works amazing for the patient. They teach them how to use, like you said, how to use that diaphragm, because the diaphragm is the core muscle that is going to move that lung up and down. So if you can learn how to take control of that and really take that deep breath, that sense of shortness of breath dramatically improves.
Right, and that's important. Wow.
Ray from Gilbert wants to know, is it possible when you're eating to swallow something the wrong way and have a piece of food go down into your lung?
Yeah, absolutely. I mean, there's many conditions, especially when someone develops pulmonary limitations and they start to weaken because they're getting more short of breath and they can't walk and they get some muscle limitations. A lot of times we can swallow things down a wrong pipe, and we do that almost on many of us do that on a daily basis. It's called aspiration. And if we aspirate a food particle or a liquid into our lung, it triggers usually a voracious cough. as our body tries to expel it out.
Right.
The problem is that if you have some lung disease of sorts and liquid or food particles go down, it actually can cause an acute inflammation in that lung and actually trigger a negative response in that lung. So a lot of our patients can actually develop a pneumonia from that.
Like a pneumonitis.
Exactly.
Yeah, like an inflammation.
You can develop inflammation. If it's food and it can't come out, you can actually develop, obviously a pneumonia because the bacteria gets infected. So it just depends on how healthy that person is. But I think the key is that if that happens continuously, you should alert your physician that, when I tend to swallow either liquids or food, I feel like I'm coughing or I feel like I'm swallowing the wrong pipe, and they need to be aware of that because maybe your vocal cords aren't working that well.
Sure.
Or you don't have the ability to block it, because normally when we swallow, we're supposed to protect our lungs as a normal response.
Exactly.
So that needs to be worked out.
Getting back to pulmonary hypertension, are there other medications that we need to watch out for that may be linked to increasing the risk of pulmonary hypertension? I know we talked about fen-phen.
Right.
But is there anything else, any antidepressants or anything else on the market that?
So it's really hard to prove if a medication is the true, cause of developing that pulmonary hypertension.
Mm-hmm.
At one point, potentially there was, antidepressants, but at the same time, there was some studies that show that maybe antidepressants may be helpful in this condition.
Okay. Mm-hmm.
Unfortunately, never bored out either way.
Mm-hmm.
But what I think is the key aspect, from a physician standpoint, I think that to look out for this condition in a patient that is 30 to 50, 60 years old, that you just can't explain the shortness of breath. And it's really termed unexplained dyspnea or unexplained shortness of breath. We don't know why you're so short of breath. This is one of those conditions where you say, you know what, I've looked for X, Y, and Z. Those are the most common things. It's not
and
that.
It's not there. Right.
Let me look for this condition.
Yeah. The new with smoking, they have the vaporized smoking cigarettes that we see. Have you seen, or is there any studies looking at a higher incidence of pulmonary hypertension or fibrosis, for that matter, using those cigarettes to help stop smoking?
Not at this point.
Okay.
Not at this point. And, maybe because the conditions we're talking about are extremely rare. You're looking at maybe 100,000 cases in the whole United States. So it may just be that, we're not finding any association because there's so few people who have the condition, and then there may be even a smaller number that actually use the vaporized cigarettes.
That's interesting. Any other questions? Is there a hereditary component to it?
Yeah, absolutely there is. And, it's a very sad situation when you meet the family where, the dad has it, and then, one or two of the children have it, and then, an aunt has it. Because what's happening is that in some of these cases, the parents are outliving the children.
Wow.
Depending on how severe it actually comes. But that's actually fairly rare, and a lot of genetic work is being conducted in pulmonary hypertension. And there's a mutation called a BMPR2 mutation, which patients who do have it can be predisposed to pulmonary hypertension. It doesn't necessarily mean you'll get it. But at this point in time, we don't recommend that if you have pulmonary hypertension, you go get genetic testing right away.
Right.
I think we recommend it in terms of a research component. And, the core center is actually based out in Utah. That's where we usually recommend patients to go if they're interested in learning more about it. But if it's hereditary because there's a direct family association to it.
Okay.
The same thing goes with pulmonary hypertension. We actually transplanted when I was at UCLA 2 siblings.
Really?
They both had the same condition, and like I said, we didn't know the etiology of it. One came in 5 years before the other one got transplanted, and 5 years later, the sister walks in, actually with her brother, who was
transplanted.
5 years later, still doing well. And he says, "My sister has the same thing. How did this happen?"
Wow.
And unfortunately, we don't have the answers for him. All we know is that there was definitely a familial association with that. So, unfortunately, there are some rare and very aggressive conditions like these that have a hereditary component, and it's very sad, but a lot of work still needs to be done on it. And that's why, I think it's very important that if you do have these conditions, it's important that you let your physician know to be referred to, individuals that have either an interest or an expertise or some research interest, because this is how science is advanced. we also hope that in doing so, the patient actually gets better care or more opportunities to newer medications that may improve their conditions, and also education on why they have their condition and what options are available for him or her.
Absolutely. We have a question.
Yes, Mel from Globe. Been a mining worker for 30 plus years. I have breathing problems. Anything I can do to help at this point?
It's a pretty broad question, but I think what we would recommend for Mel to do is that if she feels that clearly her shortness of breath has been worsening as she is continuing to do her work in the mines,
or he.
It was a he, yeah.
It was a he, sorry for that.
Mm-hmm.
That he should seek some attention to initially his internist or family practitioner and say, listen, I've been noticing that above and beyond my normal sense of shortness of breath, it seems to be a little bit worse, especially if Mel notices that when he goes to work that he may be triggering a cough or triggering that when he comes out he just has trouble breathing, or that when he goes for a small run, if that's what he does, that it's more difficult. And the first thing that needs to be done is actually just to get a simple x-ray and find out, is there anything abnormal on that x-ray? And specifically in mining workers, you can start to develop what's called an exposure injury, or like what's called a pneumonitis. You can develop, the term is called interstitial lung disease.
Right.
And these are abnormal markings on the x-ray that the radiologist will see. And if the radiologist sees that, then we would pursue a further evaluation where we would eventually do a CAT scan of the chest, which is a more fine sort of imaging cuts of the lung that we really can sort of look inside the person's lung and kind of see what's going on with the texture of the lung. And if we find abnormal features inside the lung, then absolutely we would move forward with trying to find out what this condition is and how we can try to improve the symptoms.
Right. And get them on maximum treatment.
Absolutely. And maybe, in mining cases, many times the core exposure is the constant work environment of mining itself. So especially in Mel's condition, if it's very concerning, this needs to be evaluated.
Right, sure. Even a change of job sometimes, is recommended.
Absolutely.
Yeah, that's interesting. Any other questions? We're good. Okay. It's fascinating when you really think about how complex the lung is. In children, do you see any conditions in children?
Yeah,
at
absolutely. All? I mean, I think that as an adult pulmonologist, I try to see patients that are mostly above 18, 21 years old.
Right.
But that being said, when you're dealing with rare lung diseases, we get consults from also our pediatric colleagues. And in children, of course, what's common is common, and children usually develop like asthmatic conditions.
Right.
But in terms of rare lung diseases, absolutely, children can also develop pulmonary fibrosis. And in fact, transplantation in pediatrics, one of the biggest indications is actually pulmonary hypertension.
Wow.
So these are the children who are 10, 11, 12 years old who may be born with a congenital heart defect, and they develop this high pressure, and we have to transplant them at the age of 10 or 12. In fact, we have a gal that I take care of initially from UCLA and now at St. Joe's, who was transplanted initially at 14 years old, and at age 22 is still going for second transplant. So there's all sorts of rare lung conditions that children can get that you need to watch out for. You can develop rare sort of emphysematous areas. You can develop rare types of what we call diffuse lung diseases in children. So I think that again, these are fairly rare, and we don't advocate parents who their kids are short of breath to do $1 million tests, but it's really those cases where the child is short of breath, and the physician has done an exhaustive workup, and you're like, I just don't get why your child is like that. And we don't want to say that, maybe they're they just need to get up and move around, or they're lazy, or they're those are probably not the right things to actually say, but actually say, listen, we should look for some of these rare lung conditions.
Right, to make sure.
Exactly. And that's where you would want to send to a specialist at that point in time to look for.
Right. Just in general, we talk about nutrition now as medicine a lot of times. Is there anything, in your opinion, as a pulmonologist, not necessarily in the rare lung condition, but any nutritional benefit to the lung? we know that omega-3s are good for the brain, and those kinds of things. Anything in particular that that you're aware of that just for our listeners to know?
I don't know of any, a specific supplement that has been proven. What I do know, in fact, is that, high levels of vitamin A is actually not good for the lung.
Okay.
That was actually borne out, and it was, vitamin A was thought that, okay, you take vitamin A, the lung gets sort of healed. And, the NIH actually did a very large study, and turns out those patients were exposed to higher risk of lung cancer. So I think that what we usually recommend our patients is that when it comes to nutrition, that we have no issues with them taking multivitamins and supplements, but they need to do that with some caution and not overindulge in any one thing excessively.
So from a lung perspective, you would be more concerned with some of the fat-soluble vitamins, A, D, E, K, to be more toxic.
Yeah, potentially.
To the lung.
Yeah, potentially.
And then just in general, well-balanced, fresh fruits, vegetables, that kind of thing.
Absolutely. I think, there's a lot of work being done on sort of radicals and, the use of antioxidants. And I think a lot of stuff still needs to be borne out. So there's a lot of theoretical benefits, in several of these medications. I think what all these nutritional supplements are doing is essentially telling you that you should be very well balanced in your diet.
Exactly.
And not overindulge in any one thing, not too much fats, not too much proteins, not too much carbohydrates, but really following, the standard nutritional guidelines and really adhering to that, I think not only helps the lungs, but also helps the whole body
the
in
entire
general.
body. Absolutely. Yeah.
Cindy from Mesa would like to know, is there a way to get cleared to become a scuba diver, and she has asthma? Is there something because she's been turned down in the past? Yeah.
So with scuba diving, unfortunately, an asthma history, especially depending on the severity, is it's very tough to sort of get cleared through that. I don't know how old she is, but with time, sometimes asthma can be sort of childhood or teenage, and then there's a variant called adult-induced asthma. So sometimes with time, that asthma actually resolves. Also, we talked about the environment, and it's really interesting how people who have asthma, and they live in, a certain city, and then they move and they're like, I suddenly don't have asthma anymore. Like exactly. I can breathe fine. So, it's also, it may not be actually their own lungs. It's actually maybe a reaction to where they're living. Or their job exposure. I remember, like I said in the beginning, it's amazing. There's lung diseases that, being exposed to certain types of parakeets, pigeons, and that can cause horrible lung disease.
Right.
And, the key is you actually get rid of those exposures, and you actually dramatically improve.
Isn't that interesting?
So I think with her case, I would sort of look into that and see is there something else, and that maybe can bring her to sort of do that.
Interesting. Do you believe the hour is up?
Is that right?
Yeah.
This is too much fun.
It really, really is. This has been a fantastic show. The information that you've given has just been great. Thank you so much.
I really enjoyed it.
For being here. Let's see if there's one more question that we can take. We have just 2 minutes to go, and then Joe, do you have a question?
I didn't write it down. I got the gist, but I was going to give him an email. But what the gist of the question was, Ted from Denver travels or lives in Denver. You know what? Let him email you.
All right.
Sorry, I didn't write it down.
Okay, good.
No problem at all.
I think... this has just been really, really great. Anything else, just to wrap up, that we want to, give our listeners just in general, just for lung health and.
Yeah, I think it sort of goes that if you feel you're short of breath, the first thing to do is to sort of try to modify your lifestyle. Try to see is there anything you can do from a nutritional standpoint, from an exercise standpoint, from even when the ozone
weight
layers
loss,
are high,
those kinds of things.
Absolutely. And, summertime, when there's a smog alert and ozone alert, stay indoors. Try to avoid, directly exposing yourself to those things. So sort of, modifications of and ensure sort of a healthy lifestyle. The second thing is don't be scared about actually seeing your physician when you have a problem. Don't wait till things get too advanced to where, you're really struggling. I think the key for preventative health care is exactly that, is that you go for your yearly checkups. You be very frank with your physician about what your signs and symptoms are. Let them know what you have issues with, and then the appropriate tests will be done. And that's probably the best way to catch problems early and also to prevent problems from actually progressing. And I think if you do those, I think you will cut out about 90% of all the problems that occur. The ones that are, of course, more advanced, then the physician will, of course, refer you to the appropriate pulmonologist at that time, where the correct and appropriate diagnostic tests will be taken at that time.
Right. And certainly can be treated. I mean, that's the whole idea. I mean, that's the good news with what we're really talking about.
And I think, there's a vast amount of information available to people from a medical perspective. And to make sure you read the source it's coming from, there's certain medical journals that are appropriate, and there's other sites that may not have, accurate information. So just be cautious about what you're reading. And then, of course, talk to your physician about what you're thinking and some of the things you've learned, and make sure you're reading the right material. Very
good. Well, I got to tell you, you really are an asset to the community here. To know that Phoenix, Arizona, now at St. Joe's they're doing lung transplants. To know that somebody like you is here practicing really gives me. It makes me feel good that that at least we have a community, a healthcare community that we feel comfortable with.
Right.
We don't have to send them out of state.
Right.
It really lends to that comfort. So thank you for being here.
I appreciate it. I just want to say that, of course, it's not only me. We have a fantastic team.
I'm sure
that are extremely dedicated, and of course, the hospital system has been fascinating and fantastic to the patients. So
that's great.
Appreciate the time.
Excellent. Well, thank you.
Thank you,
Joe. That wraps up our show.
All righty.
We have some really good shows coming up. For those of you out there, make sure that you go on to our Facebook page. And like us if you haven't. We have a lot of good resources. Excerpts from this show will be on there on the DocTalk 1 YouTube channel, so that's good. And we just really want to keep information, try to get people educated about healthcare, how to stay healthy, how to prevent, bad things from happening. So thank you for watching. This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.